The cardiovascular system, Part 2. This lesson will introduce the physiology of the heart and the processes and actions that control heart rate, rhythm, and also blood flow. In the first lesson regarding the cardiovascular system, we looked at the anatomy of the heart. We also reviewed the various blood vessels, the heart chambers and valves, and also the path of blood flow through the heart and the circulatory system. During this lesson, we're going to look again at the cardiovascular system, but we're going to look more closely at how the heart works and why. We will also look at the systems that help the heart beat consistently and efficiently, which is known as the physiology of the heart. When looking at the heart and the cardiovascular system, there is more to the heart than just where the blood enters and exits the heart. There are many processes that we may not be able to see, however we can see the effects of those processes working, such as when the heart does beat or the patterns of the waves of an electrocardiogram. Have you ever thought about what makes the heart pump when it does and why it needs to work in a normal rhythm? What about why the heart beats fast or sometimes slow? When you listen to the heart of a patient through a stethoscope, have you thought about what is happening with each sound? Well, this lesson is intended to help you look at some of those processes of the heart and also the control mechanisms that the body has to help the heart function and maintain homeostasis and blood flow within the body. During this lesson, we will introduce basic cardiac physiology. Many of the actions of the heart muscle are created by impulses that are generated by the cardiac conduction system. We are also going to look at how to track those impulses through the waves of the ECG and how these relate to cardiac function. Finally, we will discuss the factors that may affect blood flow and also cardiac output. In order for the heart to maintain homeostasis or balance within the organ systems and tissues, there has to be a continuous and controlled movement of blood. The blood works to deliver nutrients, oxygen, and other essential substances to the cell. It also works to remove waste products from the cells and eliminate them from the body. In order for this to occur, blood has to be in constant movement to the capillaries so that it can be delivered to the cells and then the cellular fluids. There are a variety of control mechanisms that regulate different areas of the cardiovascular system. Some of these are going to directly affect the pumping activity of the heart, the rate and the rhythm, while others are going to have a direct impact on the mechanisms that are used to direct and control blood flow. Before we look at the electrical impulses through the heart, let's review systemic and pulmonary circulation as we discussed in the anatomy lesson. Beginning with number 1 in this diagram, remember that the left ventricle will pump oxygenated blood through the aortic valve into the aorta. The aorta then branches into arteries. As blood travels, it is able to reach organs, tissues, and travel to the thin-walled capillaries to reach cells. This is also where gas exchange occurs. Oxygenated blood is delivered and deoxygenated blood is able to return through the venules. Remember back to basic cellular processes and absorption or diffusion. A substance of high concentration moves to an area of low concentration, so this is how the gas exchange occurs between the oxygenated and deoxygenated blood. Once the exchange has taken place, the venules will merge to veins and return the blood to the heart to the right atrium. Blood then travels from the right atrium through the tricuspid valve into the right ventricle and then through the pulmonary valve and into the pulmonary trunk and pulmonary arteries, where the deoxygenated blood is then delivered to the lungs. Gas exchange occurs in the lungs, oxygenating the deoxygenated blood, and then the oxygenated blood is able to return to the heart through the pulmonary veins and delivered to the left atrium, where we are back to step 1 to begin the cycle again. Now that we have reviewed pulmonary and systemic circulation, let's take a look at some of the electrical impulses that control and regulate this process. The cardiac conduction system of the heart is also known as the electrical conduction system of the heart. This system, as you might be able to tell by the name, works in the heart to coordinate the electrical impulses that control and regulate the contractions of the heart muscle. There are four structures that make up the cardiac conduction system of the heart. They are the SA node, or the sinoatrial node, the AV node, or the atrioventricular node, the AV bundle, and also the Purkinje fibers. So what exactly makes the heart beat? Unless you have a pacemaker, there's not necessarily anything mechanical in there that is going to make the heart beat, and your heart does not require batteries. However, it does have the same electrical principles as maybe something that does require batteries. The muscles of the heart are controlled by nerve impulses. In future lessons, we will look at the autonomic nervous system, and that will go into more detail about the different nerve impulses and the required neurotransmitters that occur to create the nerve impulses within various muscle cells. That's exactly what the heart is. It's a muscle, and it relies on the various nerve impulses to create the actual heartbeats that pump the blood throughout the circulatory system. In the lesson that reviewed anatomy of the heart, we discussed that the heart is made up of cardiac muscle fibers. The cardiac muscle is specifically designed to be a muscle for contraction. However, there are also cardiac muscle tissues that are even more specialized, and they permit generation or conduction of an action potential or a nerve impulse, and this is similar to an electrical current. The cardiac muscle tissue that generates the mechanical contraction of the heart begins in the SA node, or the sinoatrial node, which in this diagram is identified by number 1. This is the beginning of the cardiac conduction system and cycle. The SA node is known as the pacemaker of the heart. The SA node is located in the atrial epicardium of the right atria, where it connects with the superior vena cava. Remember, the epicardium is the inner layer of the heart muscle, and the vena cava returns blood to the heart from circulation in the body. Cardiac muscle cells are designed in that they can transmit an electrical impulse from one muscle cell to another, similar to a water ripple. You drop an object in the water, usually initial response in the water is created, something usually similar to a small splash, and then you have several ripples that will come from that initial splash. When an electrical impulse is generated and transmitted from the SA node, the impulse then travels to both atria, which cause them to contract and force blood through the AV valves into the ventricles. The nerve impulse also travels through cardiac muscle cells and stimulates the AV node or the atrioventricular node that is identified in our diagram by number 2. Now there is a slight delay between the impulse that is being sent from the atria to the ventricles. This will allow the atria to contract and push blood into the ventricles. If the more muscular ventricles were contracting at the same time, the atria would not be able to push blood with an equal amount of force as the ventricles. Now the electrical impulse from the AV node then travels to the bundle of His, and this is identified in our diagram by number 3. The bundle of His then branches into both right and left bundles, and these are identified by number 4 in our diagram. Each of these bundles will also contain Purkinje fibers, which are shown at number 5. The Purkinje fibers will carry the electrical impulses to the ventricular myocardium. And remember, myocardium is the correct term for heart muscle. Think about the pathway for just a second. As the nerve impulse first reaches the apex of the heart, remember this is the pointed end of the heart, as it travels down the bundle of His, we know that the impulse will travel through muscle cells like a wave. So the ventricular contraction is going to begin at the apex of the heart and will move upwards towards the base. The force of the apex to the base contraction helps the ventricles to push blood into circulation through the aorta and pulmonary arteries that are located at the base of the heart. The term cardiac cycle refers to the complete heartbeat. It consists of the cycle that includes a contraction and relaxation of both the atria and the ventricles. While there are several impulses and events that occur during one cardiac cycle, it is broken into two primary parts: systole, which is the contraction of the heart muscle, and the diastole, which refers to the relaxation of the heart muscle. So how does an ECG give information about the heart? Well, first of all, what is an ECG? An ECG, or an electrocardiogram, is an instrument that is used to give us a lot of information about the heart. You may also sometimes hear it referred to as an EKG. The ECG is the instrument that is used to measure the electrical activity or the impulses of the heart, not the actual contractions of the heart muscle, but the electrical impulses that are occurring to bring about the contractions of the heart muscle. Electrodes are placed at various areas on the skin of the patient, and the electrical impulse received by those electrodes are then reported to an electrocardiograph, which is the machine that measures and reports any changes in the electrical impulses. Before an electrical impulse of the heart begins, the wave or the resting image we would see on an ECG is a straight line. As a change in the voltage is recorded by the electrodes due to an electrical impulse, those are then reported to the electrocardiograph, and it creates a wave or a bump in the straight line. An ECG simply provides a visual image of the rate and the rhythm of the heart, and this will provide the doctor information regarding not only how frequently the heart is beating, but also the strength and length of contractions and the time in between contractions. Now let's put together our knowledge of cardiac conduction and the cardiac cycle. We've all seen the images of the ECG, so how does this apply to the effects and responses of cardiac conduction? As action potentials work through the heart, they are going to generate electrical currents or nerve impulses, and these are recorded by the ECG. Let's trace the electrical impulses and the response of the heart through a complete cardiac cycle. At the beginning of the wave in number 1, we see a straight flat line. This indicates that there are not any electrical impulses at this point. During depolarization of the atria, the contractile fibers of the heart muscle are going to produce the P wave. At this time also there will be relaxation of both the atria and the ventricles. This process is triggered by the action potential at the SA node. Remember, the SA node is the pacemaker of the heart. As we progress to step 2, the peak of the P wave is indicated when the atria contract or during atrial systole. There is then the slight delay in electrical impulses at the AV node, and then we move into step 3. There is depolarization of the ventricular contractile fibers that are going to produce the QRS complex. This is the process that occurs as the electrical impulses travel from the AV node to the bundle of His, and then to the Purkinje fibers and the entire ventricular myocardium. The QRS waves are so close together, as this is a very quick process. Now at the same time the QRS complex is occurring, the atria are relaxing and preparing again for the P wave. This is usually not evident on the ECG, as the QRS complex is a much stronger electrical impulse. Now this is going to lead us to step 4, which is ventricular systole, or contraction. Blood is then ejected from the heart into circulation, and the repolarization of the ventricular contractile fibers are going to produce the T wave of the ECG. This then brings us to ventricular diastole, which is relaxation of the ventricular contractile fibers. After the P wave begins, the atria will contract, and this is atrial systole. Now let's look at the ECG waves in a complete sequence. First, we have the P wave that indicates the depolarization of the atria. During this wave, the electrical impulse is traveling from the SA node through the muscles of the atria. The wave then moves to the QRS complex, which represents depolarization of the ventricles. Remember, at the same time that the QRS complex is taking place, atrial repolarization is also taking place. Also remember that the reason why atrial repolarization is not also represented by a wave is that the QRS complex produces a much stronger response and will overshadow any voltage fluctuation that might be picked up on an electrocardiograph. So technically, the QRS complex represents ventricle depolarization and atrial repolarization. Next is the T wave. This will represent repolarization of the ventricles. Occasionally, a U wave may also be seen following the T wave, and this would represent late repolarization of the Purkinje fibers in the papillary muscle of the myocardium of the ventricles. While a slight U wave may be normal, a larger and consistent U wave may indicate things such as hypokalemia or low blood potassium, or possibly a product of some heart medications. Now let's take a minute to look at an unlabeled ECG wave. Can you identify the P wave? Do you know what the P wave represents? What about the QRS complex? Finally, what about the T wave? Make sure that you are able to discuss what is occurring during each of these waves and what electrical impulses these will represent in cardiac function. When looking at cardiac function, one of the big components that we look at is blood pressure and circulation. One of the big factors that can affect cardiac output is peripheral resistance. Peripheral resistance is defined as resistance to blood flow that is imposed by the force of friction between blood and the walls of its vessels. This is a process that influences arterial blood pressure. There are many factors that may affect peripheral resistance, and some of these are going to include blood viscosity and also the diameter of the vessels and arterioles. Now, blood viscosity is going to refer to the characteristics of the blood, or the stickiness of the blood, which will flow more freely through a tube, syrup, or water. The thicker the blood, or the higher the hematocrit or packed cell volume of the red blood cells, the more resistance it will have in moving through the circulatory system. Another factor is going to be the amount of protein molecules that are present in the blood. An increase or decrease in either hematocrit or protein levels may affect blood viscosity and peripheral resistance. Under normal conditions, viscosity does not change rapidly. Where this can become an issue is in situations such as with severe anemia or even a hemorrhage. This can lower the peripheral resistance and also the arterial pressure, which can ultimately lead to circulatory failure. The diameter of the arterioles refers to the diameter of the lumen of the arterioles, as indicated in the diagram on the far right of the screen. We will look more at how diameter of the arterioles applies to peripheral resistance a little more closely in an upcoming slide. So why do we pay so much attention to the ECG and heart rate and rhythm? Well, it all comes down to tissue perfusion and oxygenation of the cells and tissues. Of course, in order for this to occur, there has to be adequate cardiac output. Cardiac output is the measurement of the amount of blood that actually leaves the heart. This volume can be determined by two different factors: stroke volume, which is the amount or the volume of blood that is ejected with each contraction, and also the heart rate, which is the frequency of contractions of the heart muscle. Cardiac output is equal to stroke volume, represented by SV, times heart rate, which is represented by HR. So how do we calculate this? If we need to know cardiac output and ejected from the heart every minute, you're going to multiply that times your heart rate, which in this example is 60 beats per minute. If you multiply 2 mLs per minute times 60 beats per minute, you're going to come out with 120 mLs per minute. So this is your measurement of cardiac output from this particular patient. How will peripheral resistance influence and affect blood pressure? Peripheral resistance will help to determine arterial blood pressure. Remember that peripheral resistance is the resistance to blood flow imposed by the force of friction between blood and the walls of the vessels. This is why the arterial blood pressure will tend to vary with peripheral resistance. As we discussed on the previous slide, part of this is due to the friction due to viscosity and the diameter of the arterioles and the capillaries. Another way peripheral resistance may influence blood pressure is the ability or lack of ability of the arterioles to constrict or dilate. Vasodilation will tend to cause a decrease in blood pressure, while vasoconstriction may cause an increase in blood pressure. Peripheral resistance helps to determine arterial pressure by controlling the rate of blood that runs out of the arteries into the arterioles. The greater the resistance, the less the arterial runoff or outflow is going to be. The more blood left in the arteries, the higher the arterial pressure will be. This diagram reviews how the change in diameter of a vessel may affect blood flow when vasoconstriction or vasodilation is present. In this example, the blood pressure is measured at a constant. However, the diameter of the lumen of the vessel is going to affect the peripheral resistance and the amount of blood that will flow through that vessel. The middle diagram represents normal dilation of a vessel, and in this example, blood flow is at 16 milliliters per minute. The arterioles have a muscular layer and a component which allows them to dilate and constrict with blood pressure and blood volume. This means the lumen may need to increase or decrease in diameter to accommodate blood changes. This also aids with changing the amount of resistance to blood flow. In this diagram, vasodilation is indicated in the bottom picture on the screen. Vasodilation is an increase in blood vessel diameter, and it may be caused by relaxation of vascular muscles, which may be triggered by a response from the autonomic nervous system, or it can be chemically induced as a result of medications. Vasodilation may also decrease blood pressure if the pressure is not at a constant. The example at the top of the screen demonstrates vasoconstriction, as there is a decrease in the size of the lumen, which will also increase the peripheral resistance, or the friction that is generated between the blood as it flows through the vessel and the wall of that vessel. What this does is it can increase blood pressure, and it may also create a change in blood flow. Now, when thinking about peripheral resistance and blood flow, a good example is water flowing through a water hose. Now, once you turn on that water hose at the main water hydrant, if you have a controlled amount of water flowing, what happens if you use a hose with a smaller diameter versus a hose with a larger diameter? If you measure the pressure, the water is going to flow through at a higher pressure through the hose that has the smaller diameter. On the flip side of that, the water goes through at a much lower pressure in the hose with the larger diameter. Blood works the same way through our vessels. It's going to flow through the smaller vessel with greater pressure, and it will go through the vessel with a larger diameter at a lower pressure. Small changes in vessel diameter may cause large changes in peripheral resistance, and as a result, changes in blood flow and blood pressure. There are also factors other than stroke volume and heart rate that may affect cardiac output. One of these is Starling's law. Starling's law is a theory that states the increased filling of the heart will result in increased cardiac contraction and will mean a slight stretch of the ventricular muscles, which will increase the force of contraction of that muscle. Changes in blood pressure may also have an effect on cardiac output, as it can have an effect on both stroke volume and heart rate. This is why when a patient experiences sudden vasodilation or fluid or blood loss, a doctor may quickly administer fluids. What this does is it's going to place fluids back into venous circulation and help fill and take up some of the space in the vessels. This will in turn help to return blood pressure and cardiac output to a more normal range. The autonomic nervous system may also chemically affect normal processes and increase blood pressure and cardiac output when necessary to increase maybe stroke volume or blood pressure. General anesthesia may also affect cardiac output by stimulating the parasympathetic nervous system, and this may produce effects that decrease heart rate and stroke volume and may lead to decreased cardiac output. If these reactions are anticipated with anesthetic agents, pre-anesthetic agents are given prior to the induction of anesthesia to help support cardiac function and minimize the effects of the anesthetic agent on cardiac output. Now that we have discussed both cardiac anatomy and physiology, how does this exactly apply to pharmacology, and why would we discuss these topics in this course? Well, I feel the best way to understand how medications are affecting your patients and also what types of actions or reactions should occur with each drug or medication, that you need to have a basic understanding of how that particular body system works. Many drugs, whether cardiac or for other purposes, may have direct or indirect effects on the cardiovascular system, especially anesthetic agents, regardless of whether they are inhalant or injectable medications. Many medications may affect the cardiovascular system by either increasing or decreasing the heart rate. Sometimes this is a desired response, but sometimes this can be a side effect, and other medications can be used to counteract or support cardiac function. Medications may also affect heart rhythm by either speeding it up, slowing it down, or simply regulating the heart rate and rhythm and encouraging consistency in the rate and rhythm. Some drugs may promote vasoconstriction, while other drugs will encourage vasodilation. Other drugs, such as Lasix, may decrease blood volume by removing excess fluid from the patient, and this could not only affect the blood volume, but also the blood pressure and the hydration status of the patient, which could ultimately affect the blood viscosity and then have an effect on peripheral resistance and possibly cardiac output. While some drugs may be used to treat some conditions, this same drug may cause secondary effects in other body systems and functions. In conclusion, this lesson has reviewed the following topics. First of all, we worked through the basics of cardiac physiology, and we discussed the main purpose of the heart and how it works to maintain and control continuous blood flow throughout the cardiovascular system. We also reviewed the electrical impulses that work to control heart rate and rhythm and the processes that direct and control blood flow. This lesson also reviewed the components of the cardiac conduction system and how the SA node, the AV node, the bundle of His, and the Purkinje fibers work to create the cardiac conduction system, and also how they work together to regulate the electrical impulses of the heart. This lesson also introduced the ECG waves and how each wave of the PQRS complex, and sometimes T, represents an electrical activity in the heart. We also looked at how each of these waves will relate to cardiac function and how they represent the electrical impulses that occur in the heart during each contraction and relaxation of the heart muscle. This lesson also compared blood viscosity and the diameter of the arterioles and how these relate to peripheral resistance. We also looked at the factors that may affect blood flow and cardiac output, and how heart rate and stroke volume relate to cardiac output in the formula that is used to determine the amount of cardiac output. This lesson simply serves as an introduction to cardiac physiology. There is a lot more to the physiological components of the cardiovascular system. We will look a little bit closer at cardiac function, cardiac physiology, and cardiac anatomy as we look at the drugs commonly used for treatment of conditions in the patient that involve the heart or cardiac function.